Hello, I'm Dr. Jamil Shamo, Associate Professor of Medicine and Pathology at Rush University Medical Center. Welcome to this educational activity on understanding the patient perspective, individualizing therapy, and exploring novel agents to deliver optimal care for patients with myelodysplastic syndromes.
The following audio is from a three-part presentation with Dr. Jamil M. Shamo. This audio is part of a certified educational activity titled Precision Care for Myelodysplastic Syndromes, Listening to Patient Voices, Exploring New Science. To access the entire activity and complete the post-test, please go online to www.peerviewpress.com/TSD. A printable monograph, slides, practice aid, and other features are also available.
To help develop the contents of this educational activity, PVI partnered with Aplastic Anemia and MDS International Foundation and conducted an online survey of patients with MDS. I will share results from this survey throughout the presentation to highlight the perspectives, experiences, and needs of patients and identify areas requiring improvement. We'll start by discussing disease recognition and assessment. First, let's look at what patients find most challenging after being diagnosed with MDS. In our first survey question, 54 patients were asked which problems or what issues or situations relative to their MDS diagnosis were the most difficult, and you can see the results here. Problems with symptom burden or prolonged symptoms were identified by the highest percentage of patients, followed closest by concerns over prognosis and risk of progression at 20%. The myelodysplastic syndromes represent a group of heterogeneous hematopoietic stem cell disorders that share common features, including dysplasia, peripheral cytopenias, and an increased risk for progression to acute myelogenous leukemia, estimated at about 30%. Cytogenetic abnormalities are identified in up to 1/2 of MDS patients, which are very important for the diagnosis and management of this disease. When patients were asked about symptoms and what they experienced prior to the MDS diagnosis, fatigue was reported by most patients, and about 74% of them stated that they had fatigue as the most common symptom. However, it's worth noting that 22% of such patients did not experience any symptom. Dr. Steensma and colleagues had previously conducted a similar internet-based survey of 359 MDS patients to better understand the burden of disease-associated symptoms in patients with MDS, and similar to our survey, excessive fatigue was reported by most patients. Patients with MDS who are asymptomatic are frequently diagnosed because of an abnormality that was detected on a routine CBC, with anemia being the most common feature. In symptomatic patients, the range of symptoms typically depends on nature and severity of cytopenias. Symptoms stem from consequences of anemia, neutropenia, or thrombocytopenia. Patients will consequently require transfusion, develop infection, and may also have bleeding events. An accurate diagnosis relies on expertise in ordering and interpreting appropriate diagnostic tests. A bone marrow biopsy is required for making the diagnosis of MDS, as it will detect dysplasia, determine blast percentage, and obtain samples for cytogenetic and molecular studies to confirm the diagnosis and rule out other overlapping myeloid neoplasms. When patients were asked why they were referred to a hematologist or a hematologist-oncologist, they stated that anemia was the most commonly reported feature at 69%, and about 1/3 of the patients were referred because they had either neutropenia or thrombocytopenia, respectively. Although about 1/2 of the patients are referred to hematology-oncology within 3 months of symptom onset, for nearly 1/4 of the patients, a referral wasn't made until after 3 months to over a year later. The timely referral to hematology should be considered in patients who have cytopenias without a plausible explanation. In 2008, the World Health Organization updated their 2001 MDS classification schema, as can be seen on the slide. However, in 2016, the World Health Organization released an updated classification for MDS as shown on the slide. And I think we're all going to be adopting the new WHO 2016 classification moving forward when it comes to the diagnosis of MDS. The International Prognostic Scoring System, or the IPSS, for MDS is shown on the slide. It is perhaps the most commonly used prognostic scoring system in patients who have MDS, intended to estimate the survival and risk of leukemia evolution in this patient population. A revised version of the IPSS, also known as IPSS-R, has been published in 2012 by Dr. Greenberg, and it still follows the basic format for the IPSS. However, it has created two categories for blast percentage less than 5% and assigned different scores based upon the depth of cytopenias. It too increased the number of prognostic categories from 4 to 5 and incorporated 5 rather than 3 cytogenetic prognostic subgroups, and this was drawn from a very large German-Austrian study by Dr. Schanz, whereby the risk stratification was utilized and adopted by the IPSS revised version. We asked the patients we surveyed about the risk category and their familiarity with that risk category, and the majority of patients responded as having low, very low risk, or INT1 risk category. It is interesting to note that 15% did not know the risk category of MDS. Our results are comparable to the IPSS risk category as reported by Greenberg in the original publication, in that 2/3 of the patient had low to INT1 risk disease. And now we will discuss therapeutic strategies for patients with low, intermediate, and high-risk MDS. We asked the patients in our survey about therapies that they had received following their diagnosis and learned that the majority, up to 67%, were treated with blood transfusion, which is not surprising. 43% of the patients were treated with growth factors such as erythropoietin, GCSF, GM-CSF, etc., and there were a variety of other agents utilized that we'll be discussing later on in more details. Several treatment options exist for MDS, as shown on this slide. However, allogeneic stem cell transplantation continues to be the only curative treatment option. It's important for practitioners to be familiar with the IWG 2006 criteria for response assessment in MDS, because the identification of progressive disease may merit a change of therapy. Changes to the IWG hematological improvement criteria are shown. The modified IWG criteria questioned the clinical significance of minor responses initially identified in the IWG 2000 criteria and redefined red cell transfusion dependence. Choice of therapy in low-risk disease is dependent on the identification of deletion 5 abnormality, in which case lenalidomide is considered the drug of choice per the NCCN guidelines. If serum EPO level is below 500, then consideration for erythropoiesis-stimulating agents plus minus GCSF could certainly be made. Without deletion 5q, and if the serum EPO level is greater than 500, then immunosuppressive therapy, hypomethylating agents, lenalidomide, or clinical trials are all reasonable options. Anemia is a common feature for the majority of MDS patients. Erythropoiesis-stimulating agents have been reported to result in a 20 to 30% response rate, with the best responders having a low endogenous erythropoietin level that is below 500, those who have normal cytogenetics, less than 5% blast, and low transfusion requirement, meaning less than 2 units a month. Generally speaking, responses to erythropoiesis-stimulating agents should be assessed after 8 to 12 weeks of therapy. In addition, iron parameters should be monitored, and patients who have iron deficiency should have their iron repleted. Lenalidomide is a thalidomide analog with potent immunomodulatory, anti-angiogenic, and anti-neoplastic properties. It's currently approved for the treatment of transfusion-dependent anemia due to low or INT1 risk MDS associated with deletion 5q with or without additional cytogenetic abnormalities. It is also approved for the treatment of multiple myeloma and mantle cell lymphoma. The approval of lenalidomide for deletion 5q minus MDS was based on a phase 2, also known as MDS-003 trial, which evaluated the safety and efficacy of this agent in patients with deletion 5q MDS. The MDS-002 was a companion study also evaluating the role of lenalidomide in patients in non-del5q MDS. As shown here, patients with del5q MDS experienced a considerable benefit with lenalidomide versus patients with non-del5, including a higher erythroid response, greater cytogenetic response, greater increase in hemoglobin, and a significantly longer duration of response. Although lenalidomide-associated hematological toxicity was observed in both studies, it was more pronounced in patients who had del5q abnormality. Furthermore, hematological toxicity, that is greater than grade 3 thrombocytopenia and neutropenia, were the most commonly noted reason for dose modification or holding in both trials. Findings from the MDS-003 study noted that patients with del5 MDS respond favorably to lenalidomide were confirmed by the randomized placebo-controlled phase 3 MDS-004 study, in which over 200 patients were randomized to either 10 milligrams, 5 milligrams of lenalidomide versus placebo, with the primary endpoint being red cell transfusion independence at 26 weeks. Significantly more patients that were treated with either 10 or 5 milligrams of lenalidomide achieved red cell transfusion independence greater than 26 weeks after therapy versus placebo. Similar results were also found for red cell transfusion independence at 8 weeks. Lenalidomide was generally well tolerated and exhibited a characteristic safety profile. More recently, Santini and colleagues presented preliminary results of the randomized placebo-controlled phase 3 MDS-005 trial, which assessed the efficacy and safety of lenalidomide in patients with non-del5 MDS who were unresponsive or refractory to erythropoiesis-stimulating agents. Significantly more patients were treated with lenalidomide achieved red cell transfusion independence at 8 weeks versus placebo, which is consistent with the results found in the phase 2 MDS-002 trial. It should be noted, however, that lenalidomide is not yet approved by the FDA for this patient population. Antithymocyte globulin is an immunosuppressive agent which has been investigated for the treatment of MDS in multiple trials. ATG may be involved in the elimination of CD8 lymphocyte-mediated suppression of the granulocyte and monocyte progenitor cells. In the largest trial, Muldrum and colleagues treated 61 MDS patients with horse ATG, and about one-third of those patients who were transfusion dependent became transfusion independent within 8 months after the 4-day course of therapy. There were 2 other smaller trials that reported similar results as depicted on the slide. What about low-dose hypomethylating agents in low-risk MDS? This is certainly a novel concept that's been explored in an open-label phase 2 trial that looked at the efficacy of lower doses of hypomethylating agents in 91 adults with de novo or secondary IPSS low and INT1 risk MDS or CMML who had no prior exposure to hypomethylating agents. Those patients were randomized to receive either azacitidine or decitabine for 3 days every 4 weeks, and the results are shown on the slide. As can be seen, one-third of those patients actually achieved CR, and another proportion did achieve some degree of hematological improvement, proving the concept that lower doses of hypomethylating agent may be a reasonable choice for people who have low-risk disease. Another exciting agent in low-risk MDS has been luspatercept. Luspatercept is a TGF-beta superfamily ligand trap that promotes late-stage erythropoiesis and has been explored for the treatment of anemia in patients who have low-risk MDS. In fact, in a multi-center, open-label dose escalation phase 2 study demonstrated that patients can have hematological improvement and reduction in their transfusion burden when treated with this agent. Remarkably, responses were noted in patients who have a high endogenous EPO level that is greater than 500, which would have made them ineligible to receive erythropoiesis-stimulating agents. Currently, a global phase 3 study, Myelodysplastic, in patients who have very low, and intermediate risk MDS with ring sideroblast who are transfusion dependent is ongoing to explore further the role of luspatercept in this patient population. Moving on to high-risk disease. In high-risk MDS, it's very important to determine if the patient is a candidate for stem cell transplantation and whether a donor is available in order for them to undergo that procedure. If the patient is not a candidate for stem cell transplantation, which unfortunately is the case in the majority of patients who have MDS, either because of comorbidity or lack of a donor, then hypomethylating agents or enrollment on clinical trials certainly represent reasonable options. What about timing for transplantation? In a similar study previously reported by Cutler and exploring the timing for ablative stem cell transplantation, Koreth and colleagues presented a study on the role of reduced intensity transplantation in patients who have MDS relative to their risk scoring, demonstrating that patients who have low-risk disease actually have a superior overall survival with non-transplant modalities. Certainly, this was not the case in people who have high-risk MDS, because in that situation, the benefit of reduced intensity transplantation was pronounced and certainly significant in people who have high-risk disease compared to those who did not undergo transplantation, as most of them, if not all, died. Saber and colleagues conducted a similar study evaluating the outcome of 701 patients who had MDS and who had undergone transplantation between 2002 and 2006. The primary objective of that analysis was to compare outcomes based on donor type, that is, HLA-matched related donor, or MRD, versus HLA-matched unrelated donor, or MUDS. Importantly, of the patients who had a match-related donor, 30% died due to transplant-related cause, and 32% relapsed, in fact. The 3-year outcome were worse for patients who had matched unrelated donor transplantation, irrespective of whether or not they had 7 out of 8 or 8 out of 8 HLA matching, which might be accounted for by the increase in the toxicity related to graft versus host disease. Therefore, allogeneic stem cell transplantation is a very reasonable choice to consider for patients who have high-risk disease and an available match-related donor, especially because none of the treatment options that we have for those patients with this high-risk disease are curative. Recently, several somatic mutations have been identified in patients who have MDS, and it would appear that the presence of certain mutations is associated with a worse outcome, as shown on this slide. There's been tremendous amount of recent literature that associates the presence of certain somatic mutations and correlates it with certain outcomes in patients who have MDS. Therefore, assessing molecular analyses in patients who have MDS has become an important prognostic tool and could potentially aid in patient selection, particularly when it comes to transplantation. This slide depicts the analysis that was recently reported depicting the outcome of patients who had undergone transplantation dependent on their IPSS revised, as well as the presence of AXXL1, RUNX1, and TP53 genes. The slide shows that the presence of those mutations correlated with a worse outcome post-transplantation, even after accounting for the IPSS risk category. Moving on to hypomethylating agents, the survival trial, also known as AZA-001, was an open-label randomized phase 3 study that examined the use of azacitidine in the treatment of intermediate 2 and high-risk MDS. In that trial, 358 subjects with high-risk MDS, including CMML, were randomized to either azacitidine or physician choice conventional care regimens. The primary endpoint for that study was overall survival, and patients were followed for a median of 21.1 months. The overall survival of patients significantly improved with azacitidine treatment versus conventional care regimen. In fact, at 24 months, 50% of the patients in the azacitidine arm were alive versus 25% in the conventional care arm. It is clear that azacitidine prolongs survival and delays the time to leukemia evolution in this patient population. The adverse event profile for azacitidine was consistent with its effect as a myelosuppressive agent. Peripheral cytopenias were the most common, with grade 3 and 4 thrombocytopenia and neutropenia occurring in 85 and 91% respectively. Febrile neutropenia occurred in about 13% of patients that were treated. Decitabine is the second hypomethylating agent that could be utilized in the treatment of high-risk disease. This was evaluated in a phase 3 study that compared decitabine to supportive care. Patients were stratified by their IPSS risk score and type of MDS, and then they were randomized to receive either decitabine or supportive care. Though all patients received supportive care in both arms according to published guidelines. The co-primary endpoints were overall response rate, CR and PR, according to IWG criteria, and time to AML or death. Secondary endpoints included hematological improvement, cytogenetic responses, transfusion requirement, survival, and quality of life analyses. The overall response rate, CR and PR, was 17% in the decitabine group versus 0 in the supportive care arm. And a response to decitabine was seen in all categories, including in 2 and high-risk IPSS patients. With respect to transfusion requirement, 39% of patients who received decitabine, as well as 27% of patients who received supportive care and who were transfusion dependent at baseline, became transfusion independent. The most common adverse events were neutropenia, thrombocytopenia, and anemia, febrile neutropenia, and infections. There was no difference in overall survival comparing treatment arms. However, the study was not powered to detect such a difference. This slide depicts the poor outcome of patients who have failed hypomethylating agent therapy. Those patients represent a very difficult to treat patient population with no available treatment options at present, with the exception of supportive care and enrollment on clinical trials. There are a number of novel strategies that are currently being explored for the treatment of MDS patients, including monoclonal antibodies, immune checkpoint inhibitors, inhibitors of Hedgehog pathway, mTOR inhibitors, among others, as can be seen on this slide. Here are some of the novel agents and therapeutic combinations that are being explored in high-risk MDS patients after hypomethylating failures. Rigosertib is a novel agent that has been explored in 2 phase 3 trials in patients who have high-risk disease, who have relapsed or were refractory to azanucleoside therapy. In the initial one-time trial, patients were stratified based upon blast percentage and were randomized 2-to-1 ratio to rigosertib versus best supportive care. The primary endpoint of the one-time trial was overall survival. However, the trial did not meet its primary endpoint. It was noted that patients who were refractory to azacitidine therapy demonstrated an improvement in overall survival when they were treated with the rigosertib. Hence, the second currently ongoing phase 3 study is exploring the role of rigosertib in patients who have high-risk disease and who have been shown to be refractory to treatment with hypomethylating agents, provided they did not receive more than 9 cycles of such therapy. And the study design is depicted on the slide as shown. Next, we'll discuss long-term patient management and monitoring strategies. One of the key issues when it comes to transfusion-dependent MDS patients is the issue of iron overload and its potential impact on survival. This slide depicts a worse survival of patients who had been shown to develop transfusion dependency. The NCCN guidelines and the MDS Foundation both publish guidelines for initiation of chelation therapy in patients who have MDS. As can be seen, there are minor differences between the 2 guidelines. Notably, the cutoff for serum ferritin when it comes to initiation of chelation. For example, in the NCCN guidelines, any ferritin greater than 2,500 microgram per liter requires initiation of chelation, whereas that cutoff is anything greater than 1,000 microgram per liter per the MDS Foundation chelation guidelines. I think it's reasonable to think about chelation therapy when patients continue to be transfusion dependent and have a rising ferritin, somewhere between 1,000 and 2,500, depending on the patient's transfusion need, as well as their comorbidities. And special attention has to be paid for the platelet count, as well as the kidney function relative to initiation of chelation therapy. In the patient that we surveyed, only 9% reported that they were receiving iron chelation therapy. What is needed in terms of chelation therapy for patients with MDS are prospective data that demonstrate that chelation actually improves outcomes in patients who have MDS, or perhaps improve organ function or reduce organ damage. However, those data hopefully will be forthcoming after the completion of the prospective randomized phase 2 Telester trial, which is designed to fill that knowledge gap. In that trial, patients with low to INT1 risk disease and serum ferritin exceeding 1,000 were randomized to receive either deferocyrox or placebo. The primary endpoint for this study is to assess the 5-year overall survival, as well as a suite of secondary endpoints, including safety and impact on cardiac function. Once the goal and treatments have been defined, a treatment decision has been made, and the treatment has been initiated, we must carefully monitor our patients to recognize treatment-emergent toxicities in a timely manner, to optimize the dosing of utilized agents, and evaluate for treatment response. We asked the patients we surveyed about the side effects that they had experienced during therapy, and the results are shown here. As you can see, fatigue was reported by the majority of patients, and about 40% of those patients continue to report anemia, neutropenia, and thrombocytopenia. Patients were also asked about sources of information that were provided to them to help them understand their MDS diagnosis and the side effects of their treatment that they were offered. Consistent with findings from the Pew Research studies, clinicians are still at the top source of health information in the United States. A majority of patients reported that they got information by talking to the doctors and nurses who care for them. 59% of the patients cited written material such as books and pamphlets were their sources of information. And again, as the Pew Research Foundation had reported, that online information continued to be an increasingly significant supplement to the information received from clinicians. MDS patient advocacy groups and foundation and the internet were also important resources for information on MDS. Patients were asked whether they got information about how to prevent and manage treatment-related side effects, and while 41% of the patients strongly agreed that they had received enough information from their healthcare provider, the majority had a less favorable response and felt that they could have used more information provided relative to that aspect of their care. When asked about areas in which improvement in MDS care can be made, education about the disease, prognosis, and treatment were noted by a substantial percentage of patients, as were side effects prevention and management. Survey respondents also underscored the importance of communication between healthcare provider and their patients. When patients were asked about barriers to good communication with their doctors and healthcare team, the lack of time to discuss questions during appointments and a convenient method for communicating outside of appointments, for example, by email, phone, or patient portal, were reported by about 30% of the patients. 13% of the patients reported that lack of understanding of their disease, its prognosis, and treatment option was a factor. Similarly, 11% cited a lack of high-quality information and educational resources. Patients with MDS are faced with challenging treatment decisions, and high-quality discussions about what is important to them promotes good decision-making and patient-centered care. Effective communication, therefore, is essential. An understanding of the available treatment choices, their unique side effects, and prevention and management options allows the patients to make informed decisions regarding their care. An understanding of the patient care goals allows the clinician to align care provided with what's most important to the patient. Therefore, timely and consistent discussions improve satisfaction and quality of care. Given the number of patients who seek information online, it's important to steer patients toward reliable sources of information and support, such as those that are listed here, including the Aplastic Anemia and International MDS Foundation, the MDS Foundation website, and leukemia.org. Myelodysplastic syndromes should be suspected in any patient with unexplained cytopenia. Life expectancy at the time of diagnosis depends on risk stratification and the likelihood of progression to AML. Supportive and disease-altering options are available, though there's a great need for novel therapies, and enrollment on clinical trials is highly encouraged. Prompt evaluation of cytopenias by hematologists is essential for making the diagnosis of MDS and initiating appropriate therapy. Finally, shared decision-making and patient education is key. That ends our discussion for today. I hope that you found it informative and useful. Once again, I encourage you to download the slides and practice aid for the activity. And don't forget to access the post-test and evaluation form by clicking the Get Certificate button. Thank you very much for participating in this educational activity on understanding the patient perspective, exploring new science, and achieving precision care for myelodysplastic syndromes.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening to this activity. To view the rest of the CME-CE activity, download materials, and complete the post-test for instant credit, please go online to www.peerviewpress.com/TSD. This activity is supported by an educational grant from Celgene Corporation.